My first question is, APL is a high-risk hematological disease, and the treatment strategies are crucial for improving patient survival and the quality of life. At this EHA conference, you presented the first result of the APOLL trial. Firstly, could you introduce the background of this research and why ATO combined with ATRA was chosen as a new treatment strategy?
So the Apollo trial was aimed to change a treatment paradigm in patients with acute promyelocytic leukemia, so-called APL. It's a very rare disease, and given the inventions and also the clinical studies performed in China and the US, 10 years ago, a phase 3 trial was published in so-called non-high-risk APL patients. And since then, arsenic trioxide, which is very effective in APL, plus ATRA has become the standard of care. So Apollo was a subsequent initiative where we tried to randomize high-risk APL patients into chemotherapy versus ATRA plus arsenic trioxide as the new standard of care. The study met its primary endpoint, so arsenic trioxide and ATRA plus a little bit of idarubicin is now the new standard of care for patients with high-risk APL. And I have to say it, thanks to Chinese researchers, because arsenic trioxide comes from traditional Chinese medicine and has been used there for more than 2,000 years actually, it was people and hematologists from Shanghai who first published the use of arsenic trioxide in APL patients. So it's built on their research.
My second question is, the AIDA regimen has always been the standard treatment for APL. What advantages of this difference do ATO combined with ATRA demonstrate compared to the standard AIDA protocol in the APOLL trial? What are the implications of these results for the future treatment of APL?
AIDA is an acronym and stands for ATRA plus idarubicin. So it means that, the shortcomings of this therapy as normal chemotherapy is high rate of extra and also medullary toxicity, so hair loss, neutropenic infections, bleeding events, of course, and also secondary myeloid neoplasms like MDS and AML have been reported in a large subset of patients. So the advantage of arsenic trioxide is that it has a high anti-leukemic efficacy, but a very low toxicity rate, apart from some mild QTc prolongation and some mild liver toxicity.
My third question is, the results of clinical trials are of great significance in guiding clinical practice. How do you view the clinical significance of the results of the APOLL trial? Can these results immediately apply to the treatment of APL patients? What other issues should be noted in the practice?
Yeah, I think that although these are the first results of the Apollo trial, we can already say that the primary endpoint was met in this study, so a better event-free survival for the arsenic trioxide therapy. Therefore, by tomorrow, at least in my clinic and in the majority of clinics in the European Union, I think the new therapy will be also the new treatment and standard treatment for all high-risk APL patients, and should become it, because I think based on the evidence of the Apollo trial, we can use it for our patients already.
As a complex blood disease, the treatment plan for APL needs to be personalized and adjusted according to the specific situation of the patient. What role do you think personalized therapy and precision medicine will apply in APL treatment in the future?
I think we have to differentiate between low risk and high risk APL. I think in low risk APL, the majority of patients can be cured and is basically a disease which nowadays can be effectively treated without any chemotherapy. So personalized may mean that some patients may not undergo the entire consolidation, so a de-escalation strategy could be considered. In high-risk APL, now the Apollo trial showed that arsenic trioxide plus ATRA is also very effective and can cure the majority of the patients. Our challenge still is the early death rate. So we see that patients die in the first 30 days of therapy because of bleeding or thrombosis, or they cannot be treated because they die before. So I think personalized would mean to identify those patients at risk for these early death and to give them a chance to undergo curative therapy with arsenic trioxide and ATRA.